I'd like to thank Asian Gastro 2023 อาจารย์รัตกรอาจารย์บุปผา for inviting us to this meeting. And now I'd like to introduce our first speaker, Dr. Wolfgang Papisch. He's a doctor. He obtained his PhD in 1994 in Germany, and now he's working as Global Product Manager for Autoimmunity Diagnostics at Thermo Fisher Scientific, involved in international working groups for standardization of APS testing. So please, Dr. Wolfgang. Now, today you talk about incorporating fecal calprotectin test in clinical practice. Please, Dr. Wolfgang.
Thank you a lot for your kind introduction. I would like to point out it's a great pleasure for me to be here with you today. The title of my talk today is Incorporating Fecal Calprotectin in Clinical Practice. First, of course, I would like to show you the area where we are working in. We are dealing with autoimmune diagnostics in general in many clinical areas, like you can see here, starting with connective tissue disease down to vasculitis as well. And as this is a Congress of Gastroenterology, of course, this is the area of most interest here. And I would like to focus on inflammatory bowel diseases, respectively, to be more precise, for the diagnostics here when it comes to calprotectin testing, fecal calprotectin testing, and the usage in this area and potentially in other areas as well. When it comes to the clinical practice, and I just myself was at the GP a few weeks ago, and there were quite some people actually there with gastrointestinal problems. And this is something which actually is very frequent in a general practice. We, of course, have here some challenges because the gastrointestinal issues can have a lot of different sources. They can be related to celiac disease, for example, colon cancer, food allergy as well, but also entities like IBS, irritable bowel syndrome, or inflammatory bowel disease. And the differentiation here is not trivial and sometimes really a challenge for physicians. What can be a big help actually is the testing for calprotectin in stool. Calprotectin is a calcium zinc binding protein predominantly present in the cytoplasm of cells involved in pathogen defense, and such as neutrophil granulocytes, monocytes, and macrophages. And the testing which is done here actually is against the antigen as such. Now you can imagine if we have inflammatory cells or cells related to inflammation destroyed, then we have the situation that calprotectin is released, and this calprotectin then can be detected with adequate diagnostic devices. And logically then there is a link between the amount of inflammation and the level of calprotectin found in the stool. Okay. The concentration thus is correlated actually, and this is why it makes sense here to have a quantitative measuring device. There are multiple studies showing that the kind of so-called normal level, or the level which is expected to be not related to critical situation here or to inflammation is below 50 milligram or per kilogram of stool. One aspect to be considered is that we find per se higher values of calprotectin in newborns. One reason why calprotectin testing has gained so much interest actually over the last years is that, and there are many publications related to that, that there are significant delays in diagnosing patients suffering from IBD, such as Crohn's disease or ulcerative colitis. And this is from an European investigation, and you can see here that when we look at the Crohn's disease patient, about 30% of the patients have a delay to be diagnosed, which is higher than 3 years, which is pretty significant. But fecal calprotectin can help in many ways, not just in the diagnosis, but also with the assessment of severity, which is logical because the higher the inflammation, the higher calprotectin level is. Treatment response as well is one aspect, which is also logical, as we can have an inflammation going down, then logically this should be related to calprotectin levels going down. It also can help looking at the remission. The lower the calprotectin levels get in treatment, the lower is the risk of a remission. All this has led, actually in quite some years ago already, to some guidelines or changes in guidelines related to testing for calprotectin. And one of the first uptakes here was by the NICE, and this is frequently cited because the NICE guideline is UK-based, but also internationally very frequently cited. The NICE guideline here states the following, and this is one example. Here we have persons suspected with Crohn's disease, and we have then, like you can see here, fecal calprotectin as first-line approach to be tested in order to assess a potential IBD underlying. Calprotectin in the meantime, and the difference we talk about here is just few years after first implementation of the NICE guideline, and this publication, which is from the year 2019, just a few years after that establishment of the NICE guidelines, calprotectin has become a very established marker in inflammatory bowel testing. There are different reasons for that. It helps a lot in diagnosis. It helps to find the right patients. It helps and can speed up as well the time to do a colonoscopy. I do not know the situation in your countries, but in Europe, we frequently have the scenario that you take quite some time to get an appointment for a colonoscopy. If you have the situation of a calprotectin test positive together with some clinical indications, then this very much can speed up the timing or the appointment to really get the colonoscopy. There is an international consensus available, which has been published just 2 years ago. And here, a lot of different physicians, gastroenterologists from a quite high number of countries, I think it was 11, yes, they came together, looked at a lot of publications. They put also all their knowledge and expertise together. And I think that's a very interesting publication here, bringing up good guidance how to use calprotectin in clinical practice. So they stated, for example, that quantitative tests should be preferred, which absolutely makes sense because, like said before, the level of calprotectin is related indeed to the level of inflammation. Of course, if we want to follow up patients, it makes sense to use always the same type of diagnostic device. We should keep in mind here that calprotectin testing can have quite some different results if we look at different devices. One aspect which is very much related to different results is the aspect of sampling. And I remember when we discussed actually in our company about variation of testing. I still remember that our research guys came to us and told us, we still have the possibility to get the test 2-3% better than what we have now. And we told him, very nice, very good, but please be aware. The problem here is not our solid phase. The problem is not our test. The problem is the pre-analytics. And this is where indeed the highest level of variation comes in. So one critical aspect indeed is the sampling and indeed is the correct way to do the sampling. A further interesting and important aspect is the cutoff actually. And I think you will talk later on also about the different values that can be used for the cutoff in order to assess the diagnostic sensitivity, specificity. This is quite tricky part. I mentioned before what is regarded is a value of 50 as being below that kind of normal. But the challenge is, if we look at values of 50 and regard everything above 50 positive, then we find a rather low sensitivity. And so it depends whether we want to use the test for assisting in the diagnosis, whether we want to use the test in order to assist gastroenterologists, whether a general practitioner is requesting a test. It very much depends on the setting, which cutoff to use and how to interpret. This international consensus actually looked into different aspects. One aspect is, and this is known already, fecal calprotectin is actually a surrogate non-invasive marker for gut inflammation. This is what we know. There are some good aspects with that and some, let's say, challenging aspects with this, because this affects, of course, the clinical specificity. And I remember a discussion, I think it was in South Korea actually, where a gastroenterologist told me, if I use calprotectin and that patient has eaten over that week quite some spicy food, then I might get elevated values. And that's very true. If you have the situation of anything which can cause any kind of inflammation, this can increase calprotectin levels. And this is why the clinical specificity of calprotectin is on a rather low level. On the other hand, and this is to take the good in that, is if there are elevated levels, we know that something is not correct. We know that something is going on, whatever that is. Fecal calprotectin is closely correlated with endoscopic and histological activity of disease, of IBD disease here particularly. There are very nice publications showing that the level of calprotectin go very well in line with the endoscopic findings following the patients. We should keep in mind that there is a high variability between different fecal calprotectin measurements. This is, like I said before, frequently related to the pre-analytics, so the sample preparation, the conditions of the stool as well. And this is also why there is not a globally accepted cutoff for fecal calprotectin. What you can find is that nearly all tests have a cutoff of 50 milligram per kilogram. But this is still something which needs to be interpreted in the right context. And very frequently we can see that different cutoffs are used, which makes sense because the cutoff is very much as well dependent on the local setting. Now, if we look at that study or this consensus approach, what are the significant findings in this study? Stool consistency, for example, can influence the fecal calprotectin extraction. If we have very liquid stool in the same way, like if we have very, very solid stool. And I remember one case we had in our application laboratory where we received some stool to be tested. And I think after 1 hour of ultrasonic treatment of the stick, there was still some stool in the notches. Yeah, so this was an example of a very solid stool, which was extremely difficult to be used to get proper results. Serial fecal calpro measurement in an individual patient should be performed with the same device. Like said, this is very logical. Interpretation of fecal calprotectin measurement results should include the evaluation of factors that may influence the test. What is meant by that? If there is someone, for example, having heavy nose bleeding, we have, of course, then take up of some blood due to that, which basically means the blood is incorporated, gets into the gut, there is destruction of the respective cells, calprotectin is released, which can increase the calprotectin level. Also, for example, aspirin taken can cause bleedings with the same consequences. There are multiple factors to be taken here into account. I said before also stool consistency is important, but still we should be very careful here because the presence of liquid stool per se is not regarded as contraindication for taking a fecal calprotectin test, especially keeping in mind that many patients we have in mind here have those underlying symptoms. So it's always a balance. And this is very much also country-specific or laboratory-specific. I know laboratories, they per se, in general, refuse to accept liquid stool. They come back with a stool sample which is less liquid than that one. We have other laboratories, they accept liquid stool, then you have to do a different kind of procedure, but of course it's still possible to measure that. There are, like I said, many reasons for calprotectin stool being evaluated. And I know that this list here is even not complete. You see a lot of gastrointestinal diseases, starting with colorectal cancer, polyps. Certain medication as well can cause increased calprotectin levels. Age as well may have a certain effect, and so on. So there are quite many aspects to be taken into account. If we have an increased calprotectin level, where could it come from? It can be one of these causes we are looking for, but it could also be another one. So differential diagnosis here is then very important. When you test for calprotectin, then it's of course very interesting to look at the sensitivity, specificity that you can find. And what you can see here is on the left side, the sensitivity, on the right side, the specificity. Here the specificity, here, with 74.1. And I would like to comment 1 minute on these results, because you see sensitivity is very high. Yes, usually it is very high, but it depends whether we talk an IBD patient under treatment or diagnostic. If we have IBD patients under treatment, then the levels may go down and even be negative. Clinical specificity, you can see here on a rather low level. That depends also on the cutoff which is used. Here the cutoff of 50, so a very low cutoff was used. There are not only international country-wise guidelines, there are also recommendations in the meantime from specialized center or individual authors. One which is very nice and frequently cited is this one. This is the so-called York Fecal Calprotectin Care Pathway. You can see here on the right side the details, and this is a flow, what to do if there is a suspicion of an underlying IBD, fecal calprotectin on a very high level. Here they use a cutoff of 100 milligram per kilogram, and then end in a certain probability of an underlying IBD or not. There are many usages of calprotectin discussed in addition, apart from IBD or IBS differentiation. And I would like to share a few examples for that. And one, for example, this is what I showed before. One example is actual bacterial infection. You can imagine if there are certain bacterial infections, indeed, we might find the situation of increased calprotectin levels, like you can see here. Here the testing was done with Clostridium, for example, Salmonella. What you do not see here, but which is also relevant, and this is unfortunately more and more coming up in many countries, tuberculosis. So if we have gastrointestinal tuberculosis, also there we can find partially very significantly increased levels of calprotectin. Then one area which is at first sight not so obvious, which is systemic sclerosis, but we may find a scenario also of gastrointestinal complications in systemic sclerosis. And there also calprotectin has been shown some interesting results and shown some helpful, to be very helpful as well. This is one publication, another one later on from the same authors, where they confirmed their finding later on. One area which is very much of interest is colorectal cancer as well. There have been many discussions. Can we use here calprotectin to assist in any way? And this is a really complex area, and I think you have shown, you will also look into that in detail. When we look at this, it should be obvious, just from logics, that if we have colorectal cancer, we have some inflammation, we have bleedings, we should find then logically in a way calprotectin increased. Yes, this is true in some respects. Yeah, so we will find increased levels indeed, but we need, on the other hand, to be very careful. This is a very sensitive topic, and there have been some examples or some considerations, let me put it that way. What about taking calprotectin as screening, general screening of population? And there is so far no guideline really incorporating that, which makes sense because, of course, the colonoscopy still is gold standard. But it can help particularly if we combine it with fecal, with occult blood testing. The combination can help, but it can definitely not replace here. And this is very important to be kept in mind, and it will surely not exclude a colorectal cancer. This is also, by the way, let me take that 1 minute. I have to hurry. I see that. But I was at the GP, and my GP asked me, what about your healthcare checkings? And she said, oh, you have to do this, that. And I always said, yes, I do this, but I did not the colorectal. The recommendation in Germany is, if you're 50, you should do that. I'm 61, I didn't do that. Yeah? We made a compromise. She said, okay, next year you do it, but for this year, I want you to take to do Calprotectin testing plus occult blood. If this is positive, you get an urgent, I hope not, you get an urgent colonoscopy. Good. Research gaps are there indeed when it comes to standardization of fecal calprotectin testing. And this is something we also take into account. We try to address as well. Coming from a company, you can see we have tried to, and I think we succeeded to improve our calprotectin testing in many ways, technically, performance-wise, and we constantly work on making this test easier available, better to carry out also by the laboratories. And there's a device telling me my time is up, but I would not like to stop without showing you the last picture, which is a picture from Freiburg, where I come from. And whenever I have the possibility to visit Freiburg, please contact me. I am happy to show you around. Very nice place, but I would like to make very clear, please not this time. I can guarantee you I'll go back on Tuesday. I will be shocked. Here's nicely warm. At home, it will be wet, windy, cloudy. Thanks a lot.
Thank you very much. I think I will go for the second session before we have the Q&A at the last. Okay, let's move to the second session. After you know about the principle of calprotectins from Dr. Wolfgang. So from my session, it's about how to use calprotectin level in focusing in inflammatory bowel disease. And some part overlap with your front slides have this. So the role of calprotectin in IBD, I will go over this outline. The first is when we want to diagnose, and the role for assess of disease severity after we diagnose IBD. And then the next will be after we treat the patients, can it be used as a treatment target and how its performance? And the last, after we get the patient into remissions, is there a role for it to monitor the patients to predict relapse that might happen in the future? Okay, let's see for the first, the role for diagnosis. I would like to mention the article published in Gastroenterology 4 years ago. Is a technical review on the evaluation of the patients with functional diarrhea and diarrhea predominant irritable bowel syndrome. So in this situation, we have to differentiate IBS from organic disease, which include IBD. And in this article, they did meta-analysis, and this table showed the results. As you see in this table, fecal calprotectin performs the best with the sensitivity and specificity of 81 and 87% respectively at the cutoff value of 50. And this is the cutoff value that they recommend. With this cutoff value and IBD incidence of 5%, the negative predictive value is 98%. And this value is better than other inflammatory markers, especially for the blood tests, CRP and ESR. So this test can use as the exclusion test, but when it's elevated, it doesn't mean that it is to be IBD, because many conditions can increase fecal calprotectin. We can group this into largely into two groups: the group with gut inflammations and the group with neoplasms. And on the other side, we know that the sensitivity is very good overall, but if we focus on the colorectal cancer, you see that from this study, the performance of the test is not as good as when we use it for inflammatory conditions. The AUROC is about 0.7 with the sensitivity around 70. So the recommendation at this time, like Dr. Wolfgang spoke in his sessions, the uses for exclusion of colon cancer, at this time we recommend not to use. So in the patients, if we suspect about colon cancer, we might use other investigations like fecal colonoscopy. So this comes to the recommendation that published in British Medical Journal this year. They propose that in adult patients who are younger than 60 years old, where the possibility of colon cancer is low, who present with lower GI symptoms, including abdominal pain or any other like bowel habit change, diarrhea or constipation, and you differentiate the cause between inflammatory conditions or IBS, they recommend using fecal calprotectin and use this cutoff value to guide for making decision. If the value is fairly low, the chance of IBS is very high. So in this case, if the doctor who take care of those patients are general practitioners, so there is no need to urgently refer those patients to see a specialist, and they can take care of these patients by themselves. In contrast, if the value is very high, so in this situation, the IBD or other inflammatory condition is likely. So in this condition, referring to gastroenterologist urgently is recommended. But if the value fall in between these two cutoff value, they suggest repeat testing and to see how still persistent elevation or decrease, or routine refer to gastroenterologist and avoiding once repeat the test. Recommend the patients avoid using other causes that can increase calprotectin. So this is about the diagnosis of calprotectin. For diagnosis role of calprotectin or IBD. So next, I'm gonna go to other roles. For the assessment of disease severity, I think it will relate with the correlations with the endoscopic activity. And from now, I will talk ulcerative colitis and Crohn's separately, because these two diseases may not be completely the same for calprotectin performance. So let's see ulcerative colitis first. So the first thing, how calprotectin correlate with endoscopic activity in ulcerative colitis. This is the cross-sectional study evaluating clinical index and other inflammatory markers with endoscopic findings classified by modified Baron score. And as you see in the table and this diagram, calprotectin correlated very well with severity of endoscopy, and it is the best among other inflammatory markers and clinical manifestation. And not only this, in this study, calprotectin was the only marker that could discriminate between different grades of endoscopic activity, while other parameters could not do that. And this study showed not only the severity, the correlations exist across all phenotypes of ulcerative colitis. The correlation coefficient is significant. However, it is better for the left-sided and extensive colitis. So for the correlation of with endoscopic activity, I will summarize like this. It correlates very well and across all phenotypes, better for extensive or left side and better than clinical CRP and platelets. And the next is the treatment target. We always use strike-through recommendations for treatment target in inflammatory bowel disease, and at this time, it still recommend mucosal healing at the least treatment target that we should obtain for ulcerative colitis. And let's see how it correlates with mucosal healing. So I show you in this table with 3 meta-analyses in different times, 2014, 18, and 2021. So our results are consistent. As you see, the AUROC is very high, 0.86 to 0.93, with a very high sensitivity for detect mucosal inflammation. The pool sensitivity range from 78 to 88%, let's say 80 to 90%. And for the specificity, it's about 80%. So it's very good to predict mucosal healing. But as Dr. Wolfgang say, what the sense and specs depends on the cutoff value. So what is the appropriate cutoff value? So I bring this information from the clinical practice guideline published in Gastroenterology this year. So in this recommendation, they did the meta-analysis and classified the cutoff, the sensitivity and specificity based on 3 cutoff values: 50 plus minus 50, 150 plus minus 50, and 250 plus minus 50s. And they found that the cutoff value of 150 is the best, and they recommend in UC patients who are in clinical remission using calprotectin less than this value to rule out active inflammation and avoid routine colonoscopy. And next, I'm gonna show you this study. So not only endoscopic healing, but histologic healing, which is the beyond target of treatment in the strike criteria. Calprotectin still performs very well. In this meta-analysis of 9 studies, 8 prospective and 1 post-hoc analysis, it shows that the area under summary ROC curve is 0.79 with the sense and spec of 76 and 71, and they suggest the cutoff value of 100 microgram per gram is the best. So now we know that calprotectin can be used at the treatment target, 150 for endoscopic healing and maybe 100 for histologic healing. But when that we should measure this and we expect the calprotectin into remission after we start treatment. So I show you the results of the strike-through recommendations. And in these recommendations is the expert opinions, and they grade the time to obtain treatment target. And they say that it's different between each medical treatment that the patient are receiving. For calprotectin level, it's in the purple bar, and this roughly it's about 2 to 4 months, and maybe 3 months that we expect calprotectin to be acceptable level. So in summarize for this part, I would say that the overall performance is very good with a very high sensitivity and specificity. Cutoff value, as I say, 150 for endo, 100 for histo, and the time is 2 to 4 months. And then after patients get in remission, any role for calprotectin for predicting relapse? So just to show this systematic review is evaluate the chance of relapses after 2 consecutive fecal calprotectin measurements. So it doesn't use only 1 time, it used 2 times, which may decrease the viability of the test. And there is the detail of the study and the type of the fecal calprotectin used in each study. In this systematic review, the pretest probability of relapse is 27 to 50%. And if the calprotectin is elevated for 2 times, the post-test probability of relapse increased to 53 to 83%. But if it's normal, the post-test probability is decreased to 6 to 33%. So it's say calprotectin is useful for monitoring the patients who are in clinical remission. And in this year, the meta-analysis published in Gastro did the meta-analysis of 17 cohorts, more than 1,000 patients, and they found that in the patients who have elevation of calprotectin, the risk of relapse is 4.36 times higher than the patients with normal calprotectin level. The poor relapse rate is 15% for normal calprotectin level and 65% for elevated calprotectin level. So this, we recommend in the patients with clinical remissions, if calprotectin is elevated, they suggest repeated into 3 to 6 months, bring the data from the previous systematic review. And if it's still persistent elevations, colonoscopy should be done to adjust the treatment. But if the calprotectin is in normal, they suggest monitor calprotectin level regularly every 6 to 12 months to predict subclinical inflammation and adjust the treatment before the patient get obvious clinical relapse. So for predicting the relapse, the results of the analysis I show here, and this is the recommendation. So that's all about ulcerative colitis, and for Crohn's disease, it will be go in the same passion. So for Crohn's disease, the first, I'd like to mention about the correlation with the endoscopic activity, and this cross-sectional study show that calprotectin is the best inflammatory markers to correlate it with the endoscopic severity assessed by CDEIS score, and it's significantly better than clinical activity, which is very bad, and CRP. The correlation is strong. And after that study, there are a lot of studies published in this field, and this is the systematic review 3 years ago. And this study confirmed the moderate to strong correlation of calprotectin level in Crohn's disease with the correlation coefficients of 0.56 to 0.77. So it's good as well. However, for Crohn's disease, one thing that we have to consider is the location of the disease. In this study, the same study as in the first study I mentioned, the correlation of calprotectin with endoscopic severity is excellent if the colon is involved. As you see, the correlation coefficient is very strong for ileocolonic or colonic. But in ileal location, isolated ileal disease, you see the correlation significantly as shown in this diagram, but the strength of correlation is not strong as good as we see for the colonic lesion. The ileal IL-1 ileal disease has the just moderate correlation with the fecal calprotectin. And after this study, there's a systematic review published 4 years ago, and to see the calprotectin performance in small bowel Crohn's and large bowel Crohn's disease. And this review also, they saw some study, this is the same study I showed, and another study showed strong correlation with significant correlations. But many studies show that for small bowel Crohn's disease, the correlations of calprotectin with endoscopic severity is not significant. But for confirmation for the large bowel lesions, all study confirms a strong correlation with fecal calprotectin. So for summary, calprotectin and the correlation with endoscopic activity in Crohn's, say overall is okay and good, but it's excellent for colonic location as in ulcerative colitis. And it's better than clinical and CRP anyway. So next is the target of treatment. In STRIDE 2 criteria, still recommend endoscopic mucosal healing for Crohn's as well. And I show the same 3 meta-analysis I showed you in ulcerative colitis, and in these studies show the good performance of calprotectin level when you want to predict a mucosal healing. The area under ROC 0.83 to 0.88 with the poor sensitivity around 80%, so a little bit lower than the performance for UC, which is 80 to 90%. And the specificity is 72 to 81%, a little bit lower as well, as you compare to 80% for ulcerative colitis. And the same for the correlations of endoscopic activity. The prediction of mucosal healing may be different between small bowel and large bowel lesions. For the small bowel lesions, the sensitivity seems to be less, only 43% to 100% range from this. And for large bowel is higher, 76 to 100%. And in some, the sensitivity is significantly lower. For the specificity, it's 50 to 100 for small bowel and 30 to 100 for large bowel disease. So calprotectin, based on this data, can be used as the marker for like a treatment of target as well. And how about the cutoff value? So for the cutoff value, this the systematic review published in the STRIDE 2 recommendations. That is the review here, and they recommend the same cutoff level as in UC 150 to differentiate between those with mucosal healing and no mucosal healing. However, because of more variations, they proposed other 2 cutoff value. The first is the low cutoff value of 100. This could be used as the exclusion cutoff value, and 250 could be used as the confirmation of inflammation cutoff value. So how about the time? I bring the data from the STRIDE 2 criteria as well. And lastly, the duration could be the same, 2 to 4 months. So for target of treatment, overall is okay, good, but a little bit lower than ulcerative colitis. But for ileal location, it's not as good as for colonic lesion. The cutoff is the same, 150. And the last is the predicting of disease relapse in Crohn's disease. So I'd like to show the systematic review just published this year, and this the studies included in this review. And as you see, the relapse rates appear as obviously significantly higher in the patients with elevation of calprotectin compared to those with normal calprotectin level, with the follow-up time ranging from 4 months to 24 months. So we can say that calprotectin has played a role in monitoring the patients with Crohn's disease who are in clinical remission. And in Crohn's disease, that another situation is to follow up the patients who have undergone ADO-Fecal resection or surgery, and calprotectin level plays some role for this indication as well. From this meta-analysis, it says that at the value of 150 is performed the best sensitivity and specificity, which area under summary ROC curve of 0.73. So for Crohn's disease, for predicting the relapse, we can use it, and as either the clinical remission with medical treatment or post-op recurrence, with the cutoff level of 150 for post-operative recurrence. And that's all for my talk for IBD. Thank you very much. Question
for Professor Julajak. Is there, if a patient wants to avoid colonoscopy for surveillance in IBD or post-surgical resection, how often you say fecal calprotectin is an effective monitoring tool, and how often are you looking to do the fecal calprotectin test?
Thank you very much. It's a good question. So you adjust means for after resection or after remission. After resection, okay. For after intestinal resection, we say that the patient is in surgically induced remission, and the recommendations we should do colonoscopy because it's the best thing to predict relapse at 6 to 12 months. So when I use Calprotectin, I might use it maybe before that time, 3 months, or in between the time that you have the schedule for colonoscopy. And if it's elevated, you might postpone the colonoscopy to perform earlier to prevent endoscopic relapse.
Thank you very much. And I have one question for Dr. Wolfgang. So as you mentioned, there could be many reasons why there are false positives with fecal calprotectin, such as malignancy or adenoma. So is there a role for fecal calprotectin for colorectal cancer screening and detection of adenoma instead of using a FIT test or a colonoscopy?
Is that one working? Yes. Good. It's a tricky question. Because I think we need to be careful here, because the general recommendation, I think in most countries and guidelines, is definitely for general screening to colonoscopy. And this is, I mentioned the GP where I went to, also she told me, you should do this. And I know I should have done that. Absolutely. The challenge now here is the following. I remember a discussion also with a gastroenterologist on that, and he's also involved in guidelines. And he said, basically, the problem here is the data as such are, let me put it this way, not that bad. So especially if we combine calprotectin with occult blood testing, we find a rather good sensitivity. But the problem here is, especially in early stage, there we miss some patients. The testing as such then is not appropriate to exclude colorectal cancer. And there is a big fear also, though there are also political dimension here comes in. Because if you would highlight then the combination of this not invasive testing, then there is the thinking also and the fear that patients even might go less to the gold standard, which is still their colonoscopy, and do only the non-invasive testing. And I do not know Thailand scenario, but I can tell you from Germany scenario, the recommendation is above 50 or from 50 years on, you should regularly every year do a colonoscopy for cross-check. I can tell you the take-up is, if you allow me the wording, extremely lousy, like me. The take-up most probably doing the combination calprotectin and fecal occult blood test would most probably be better, but the fear is that then the take-up to do the colonoscopy would even go down. So it's a tricky scenario here.
Okay, thank you very much.
Thank you so much, Professor Julajak and Wolfgang, for your excellent talk. I believe that many of us here, and we have many hundreds online, the participants on from Asian countries, we're not my familiar with the use of fecal calprotectin outside the indications of the IBD. And you mentioned in your slide that FCs might be one of the inferior markers and can use in other conditions, such as Atish said, colorectal cancers. You mentioned about combinations together with the FOBTs. And maybe in the systemic sclerosis. For both of you, for your experience, except for the IBD, what is the current best evidence that we can use the FC for other indications for the other clinical diseases? Please. May Julajak, you start first.
So as I mentioned, if patients come with chronic lower GI symptoms, we may be able to use calprotectin in combination with a blood test because a cord blood test is better for the neoplastic disease, but calprotectin level is better for inflammatory disease. So when the patients come and we don't know what the disease they might have, and we want to exclude all of these two conditions, we may use both tests, but depends on the cost and the availability of the test that you have. Indeed, I have a study supported by Thermo Special Specific. They provided a calprotectin test for us, and I enrolled nearly 1,000 patients coming for colonoscopy with some symptoms and to perform both tests. And I found that using both tests is better than either one alone, but FIT test is better for colorectal cancer. And from my opinion, I will not use calprotectin for the exclusion test for colorectal cancer alone, not use it alone.
So Wolfgang, for your ideas for the current evidence base, what is the other indications to use the FC in detected of the clinical diseases?
The official guidelines, if you look at that, in basically all countries, there the focus is IBD. That's very clear. Like you said, there might be other indications, yes, because what we should keep in mind is, like I said, if calprotectin is increased, there is something going on. So I, for example, and I had a discussion, I mentioned my GP. I discussed with her because I was surprised that she suggested something like this to me. And what she basically told me is, if she has issues to find an underlying cause, and if she then recommends to do calprotectin testing and there is a positivity, for her, this is kind of a gatekeeper. Yeah, which basically means, and we have big problems actually in many countries. In Germany, many European countries, we have an overload of specialists, of people wanting to go to specialists. Meaning, if the calprotectin test is positive on the general practitioner side, then this is an indication to try to find an earlier appointment with the gastroenterologist. Whether this is now IBD or whether this is now any other condition, but a positivity can indicate that there is something going on. So it's not a clear and specific indication. It is more kind of a gatekeeping strategy that she mentioned. But even this is something which is not in guidelines in most countries. I think this is most probably how different doctors in different countries per their own experience do it.
So maybe I grasp from both of you that we might use the FC as a additive test, maybe arise our concerns, not only for the IBD patients, but sometimes as an inflammatory marker, such as in colorectal cancers, advanced colorectal polyps, and some systemic sclerosis. That's going to be right. Okay.
And Dr. Wolfgang, just to follow up on what you said, that if the fecal calprotectin is raised, there is something going on. So if their patient has a raised fecal cal and then you perform a colonoscopy and it's completely normal, what would be your approach into the next step of investigation? Would you then go on to do a small bowel imaging or do an upper GI endoscopy?
I wouldn't have a recommendation.
or Professor Julajak.
Yeah, because I think this is a question more to the...
Yes.
Thank you very much. There's a problem that I made many times. So for me, I would say other characteristics, clinical symptoms, other labs is all perfect. I will monitor calprotectin. This is still elevations like 1,000. I will do small bowel endoscopy for excluding some lesions. But if the patient has something abnormal, some like low level of hematocrit, maybe not near normal, but a little bit low, I would do.
Thank you very much.
Thank you.
Maybe to Dr. Wolfgang first. I think this useful test to monitor, the relapse information and so on. but sometimes there's a concurrent infection like CMV or Clostridium difficile, and whether you can rely on the test itself or you have to go check colonoscopy at the same time, because sometimes we don't know where it's from.
Yes, this of course can also increase calprotectin levels, like you say. If we have another infection underlying, yes, absolutely. How you do that practically in the end, I must give that question to you. How you deal with that? I, as far as I know, at least, but this is from my experience, what I hear from physicians. They still use the testing as such. They try, of course, to take into account this possibility. But how this is practically done in your practice, I don't know. If there is a side infection as well.
Well, I guess we won't know the infection until we go in and check, But I'm sure Dr. Julajak will perform colonoscopy at the same time, regardless. He wouldn't. Would you, Dr. Julajak?
Ajahn means in the patients with IBD with calprotectin elevation.
Yeah, then have a high calprotectin, but at the same time, you don't know whether it's a flare-up or it's a concurrent infection.
We have to exclude other causes like drugs, infections. I might do C. difficile test. And finally, if I want to adjust the medical treatment, it should colonoscopy should be done to assess the real severity and exclude CMV infection.
And I think this marker is difficult for your small bowel disease, Crohn's disease.
Yes.
It's sensitivity is not that high. So, and it's very difficult to correlate with endoscopic finding because you cannot go in that far in your ileum.
Yeah.
So I don't know how you deal with it. With if is it high or low, or it can be low, in fact. Even with the
if
activate Crohn's small bowel only.
For example, if you are in the situation that the patient has some active disease and you get the treatment and the calprotectin level is not go to normal, in that case, if the treatment that I'm going to adjust is not very serious, for example, just increase the dose of 5-ASA or some shortcut of steroids, I may not do colonoscopy to confirm because I have evidence before of the inflammation in the past. But if the decision is to adjust the group of treatment, it's very important to define the real inflammation that happens in the patient's gut. So I think in that case, I will do endoscopy. I'm not sure that I understand. I answer right. No.
Yeah, one little additional remark as well. Indeed, we can have, when it comes to infections, for example, indeed that can increase calprotectin levels. But in many cases, the increase here in calprotectin levels is not extremely high. So if we have a real big flare of IBD, then we talk about multiples of hundreds, if not 1,000 levels, something like that. If we have an infection, then we may talk about 100, 200, something like that. So I don't know whether this helps a little bit, but this is also what we need to take into account. What is interesting is if we talk about TBC. Yeah, there I have seen, I remember one study done in India, levels of 1, 2, 3,000, like that in calprotectin, yes.
Okay, if we don't have any more questions, I would like to close the session. Thank you very much to our speakers for a very interesting talk and discussion. Thank you.
Thank you very much.